away from our scheduled time. I have an honor to transmit this first international transmission for COVID and Muka from India. The program is hosted here by NPF Canada. We have 4K equipped video transmission facility, and it's an indeed honor to have the scholarly experts all over the world from Italy, from India, from Canada, all parts of the world. And I have with me my coordinator, uh, Ms. Kamal Khandelwal, who works for Lifecare Innovation. She is the business head and marketing head. This program is supported by Lifecare Solutions. So, floor is yours, Kamal. Would you like to? I would like to take the proceedings forward from here on.
Ultimately, the greatest lesson that COVID 19 can teach humanity is that we are all in this together. Pursuit of knowledge and innovation are hallmark of human race. Good evening from India. I am Komal Khandelwal from Lifecare Innovations, pioneer of liposomal drugs. I welcome you all to this international panel discussion on most highlighted topic, Mucor and COVID. Today's event has been sponsored by Lifecare Innovations, which is a 20-year-old medical biotechnology company engaged in research, development, manufacturing, and marketing of healthcare products. It specializes in controlled release pharmaceuticals employing an array of technologies of novel drug delivery systems. Live transmission support is provided by NPF Inc. Canada, partnered with Cognitrex at India is a global scientific event, but Broadcasting Inc. is a 4K equipped video transmission facility operating with cutting edge satellite technology in the segment of healthcare, is hosting the event at St. John's, Canada. I hand over this virtual platform to Dr. Yash Javeri to chair the panel discussion. Dr. Yash Javeri is Head of Critical Care Medicine and Emergency at Regency Super Speciality Hospital at Lucknow. He is convener at Indian Sepsis Forum, Vice President of Neurocritical Care Society, CII COVID Medical Task Force member. Over to you, Dr. Yash Javeri.
Thank you, Komal. Dear friends, it's a proud privilege. I'm inviting you all on behalf of Lifecare Innovations and Indian Sepsis Forum to this international symposium. We are privileged to have renowned faculty from across the globe. Professor Chirino joins us from Italy. Dr. J.N. Verma, Dr. Lily Verma joins us from Delhi. Dr. Manish Muljal and Dr. Pooja Khosta joins us from Sir Gangaram Hospital, Delhi. The flow of the meeting will go on as the presentations will be done by various experts. At the end of the presentations, we have a panel discussion and Q&A session, which will be for about 15 minutes. I'll start the day with my presentation.
Che inizia la sua presentazione?
Chi?
Lui, chi vedo che ha parlato.
Ah sì, è l'organizzatore.
I'm going to talk about invasive fungal infections and COVID, the double whammy. Patients with severe COVID-19 are particularly vulnerable to bacterial and fungal infections. The most common fungal infections in patients with COVID-19 include aspergillosis or invasive candidiasis. We are increasingly seeing mucormycosis in COVID-19 nowadays in this part of the world. What are the reasons for the secondary infections in COVID-19? Approximately 5% of patients experience severe lung damage due to viral replication, the ensuing cytokine storm, and complex inflammatory processes. Risk of developing invasive fungal complications, especially those with the pulmonary tropism, such as mold infection, mainly aspergillosis, and pneumocystosis. There are a complex interplay of factors: immunosuppression, uncontrolled diabetes, previous respiratory ailments, immunosuppressive therapy, and systemic immune alterations which contribute to immunopathogenesis of mucormycosis and other fungal infections. What role hyperferritinemia has in mucormycosis associated with COVID has to be seen. Propensity to cause extensive pulmonary damage is seen with COVID-19, which increases the risk of invasive fungal infections. And we all know there is a huge immune dysregulation associated with COVID-19. Both innate immunity and adaptive immunity are disturbed, which further adds to the risk of invasive fungal infections. What is the epidemiology? This is a paper from United Kingdom, where White and his colleagues reported an incidence of 26.7% incidence of invasive fungal disease, including a 12.6% incidence of invasive yeast infections in COVID-19 patients. Steroids significantly increase the likelihood of COVID-associated pulmonary aspergillosis in this study also. Invasive aspergillosis is a well-described entity, especially in severe viral-related pneumonia. The incidence is huge. If we talk about severe pneumonia, it might be related to influenza, it might be related to SARS. This study showed a 19% incidence amongst influenza-related acute respiratory failure, whereas for SARS, although the numbers were very small, they had 10% patient developing invasive aspergillosis. It remains a diagnostic dilemma. The diagnosis is difficult and it is based on a body of arguments. This is especially true for critically ill patients in whom clinical arguments are not discriminant and CT scan is either lacking or difficult to analyze. This is why mycological arguments play a crucial role in the diagnostic approach. Consequently, we ask ourselves whether the use of a more stringent criteria that are not limited to a single mycological argument would be preferable. We need to revise the diagnostic criteria of aspergillosis, especially in light of COVID-19. The challenges go beyond diagnosis. Treatment is challenging. Although voriconazole is the standard first-line therapy, but we know IV therapy can prolong QT interval, and there is a potential for drug-drug and drug-food interactions with voriconazole. Cytochrome-mediated drug interactions would be considerable clinical importance in COVID-19, where lopinavir, ritonavir, azithromycin, and voriconazole, which are all inducers of cytochrome system, are being used. And many other drugs which have been used, which are not licensed to be used in COVID, are also cytochrome inducers. Isavuconazole is a new anti-mold azole, which does not have the side effect of QTC, but availability is an issue in most of the regions of the world. This is an old paper from 2009, Clinical Microbiology and Infections. Possible epigenetic mechanisms of increased virulence in Rhizopus oryzae following voriconazole exposure. So, rampant use of voriconazole, is it adding to the risk of development of voriconazole resistance? The answer is still not clear, but it adds to the risk. Voriconazole associated zygomycosis, a significant consequence of evolving antifungal prophylaxis and immunosuppression practices. What other infections we see? What other fungal infections we see in severe COVID-19? Fungal infections resistant to the traditional antifungal treatment, especially to fluconazole, have been described. Early diagnosis and monitoring for Candida infections and antifungal resistance are key to reducing death from invasive fungal infections in COVID-19. Especially Candida auris and azole-resistant aspergillus are major roadblocks to good treatment. This report comes from Delhi Emerging Infectious Disease 2020, where the group reported multi-drug resistant Candida auris infections in critical ill coronavirus disease patients. The data was from April to July, and Dr. Bansidhar was one of the authors. In New Delhi, candidemia affected 15 critically ill coronavirus disease patients. In the ICU, Candida auris accounted for two-thirds of the cases, and almost all the isolates were resistant to fluconazole. Case fatality rate was high. And we have seen such outbreaks of fluconazole resistant candida in various parts of the world. Reports of azo-resistant in kappa are emerging, and in those cases, liposomal amphotericin may be the treatment of choice. The risk group for mucormycosis are well known. However, COVID-19 is getting more and more rampant. More high-risk group patients are getting COVID, and patients with trauma, diabetes, steroid use, hematological malignancy, prolonged neutropenia, bone marrow transplant, solid organ transplant are more likely to develop mucormycosis. Disseminated mucormycosis is known and we have to look for it. Unless we don't look for it, we will not diagnose it. This was a case report of a 22-year-old gentleman with COVID-19 pneumonia and a middle cerebral artery infarct in whom disseminated mucormycosis involving the lungs and brain was incidentally discovered during a postmortem study. There is delay in diagnosis. That is why we are outreaching our clinical colleagues through this meeting. Patients face delay in reaching out because of various factors. Lockdown, there is no physical interface at times. Delay in recognition, delay in interventions. Most of the clinicians and lab personnel are not well trained in mycology, and often there is neglect on part of patient or on part of physician also. We are seeing increasing numbers. Probably the trend is not wrong. We are the capital of diabetes and invasive fungal infections. The number are not probably just an epiphenomena. We are still missing a lot of such cases, and this is again the tip of the iceberg phenomena. We have to define immunosuppression timelines. How early the patient goes into immunosuppression following COVID-19 and for how long the patient remain immunosuppressed, because the immunosuppression does just not fades away with the severe phase of the disease. Environmental factors have to be looked into. How this instrumentation with swabs and other therapies which patients have been using could contribute to invasive implantation of aspergillus has to be seen. Cultural change has to be brought for mask wearing, not only for prevention, but patients who have suffered, who remain immunosuppressed, are at risk of getting secondary infections. They should also not stop wearing masks. Mask hygiene is important. When they are doing an activity like gardening, they should not touch the soil. They should use gloves or long sleeves clothes so that the spores don't enter the body somehow. Prevention is important. The steroid use should be very, very judicious, only in the right subgroup of patients. Tight glycemic control, environmental factors. We know most of the hospitals were in makeshift arrangement. Air handling units were not appropriate. Immunosuppression duration, we are still not clear. We need to reach out to our specialists, the ENT colleagues, for early and right diagnosis. Hygiene and infection control measures will go a long way. The practice points from my talk are: COVID predisposes to invasive fungal infection. The incidence is unclear, but the numbers are significant. Awareness, early recognition, and aggressive treatment are required. I thank you. I will like to invite Professor Curino for his talk. Professor Curino joins us from Italy. He is professor and head, Department of Anesthesia and Intensive Care at San Filippo Neri Hospital, Rome. He is a well-known name in anesthesia and critical care circles, and he was at the epicenter of COVID, where I seen it all. Over to you, Professor Curino.
Hello to everyone. Thank you for this kind invitation. I drive through a very complicated field because it's really unclear the role of fungal infection during COVID-19. I am a coordinator of 500 beds of intensive care, and I saw so many COVID-19 patients, and I have no still very clear idea. I show during my speech also our very, very recent and new research. Just a few stones in the water just to start the debate. The novel COVID-19 pandemic caused by severe acute respiratory syndrome coronavirus 2 has placed an unprecedented strain on healthcare system, as we know everyone. An emerging concern is the potential impact of the novel coronavirus SARS-CoV-2 pandemic on antimicrobial resistance. Early literature reported the low rates of bacterial and fungal infection in hospitalized COVID-19 patients, but high use of empirical broad-spectrum antimicrobials. In hospital, the difficulty in clinical differentiating COVID-19 and its progression from bacterial and fungal infection provides a significant challenge to clinician and antimicrobial stewardship. High quality evidence to support decision make on bacterial and fungal infection in COVID-19 is still very limited. Clinical uncertainty is likely to drive unnecessary antimicrobial prescribing in COVID-19 patients both on during admission, potentially increasing the selection of drug resistance infection. E non ci riesco. Okay. The importance of good hygiene. The novel coronavirus disease pandemic caused by severe acute. Oh, sorry. I tried because it's not in presentation. So the recent issue of a clinical microbiology and infection, Garcia Vidal and the colleagues report the experience of a co-infection recently in a recent published and superinfection in hospitalized patients with COVID-19. Fungal co-infection was identified in only 7 patients, about 1,000 patients. That means 0.7. But this percentage are very different from many other authors. 3 patients were diagnosed with Aspergillus fumigatus and other with Candida albicans, but this infection is proved by coming from bloodstream infection, urinary tract infection, and the intra-abdominal infection. So it's very difficult to understand the process. To date, in COVID-19, no evidence has emerged to support concern regarding increased rates of co-infection with SARS-CoV-2. With documented hospital-acquired infection in COVID-19 cases has been higher. These appear to be largely associated with critical care and to be common nosocomial infection rather than directly attributable to COVID-19. Similarly, in previous coronavirus pandemics and epidemics such as SARS-1 and the Middle Eastern respiratory syndrome, little evidence of bacteria and fungal infection has been reported. In other terms, the importance of good and hygiene, aseptic technique, surveillance of multi-drug resistant organisms, and isolation must be promoted as key intervention in reducing nosocomial infection. The impact of COVID-19 on antimicrobial resistance must be carefully considered. Concerns regarding increasing antimicrobial use in hospital, overcrowding of hospitals, and the reducing in opportunities to isolate patients with multi-drug resistance organism may have a negative impact on AMR. However, this must be balanced against increased social distancing a renewed focus on hand hygiene and apparent reduction in community antimicrobial use that may have a positive impact on AMR. Although the pathophysiology of COVID-19 is not completely still understood, it's plausible that immune dysregulation and lung damage stemming from COVID-19 immunopathology facilitated Aspergillus superinfection in a way that is at least partially distinct from other respiratory viruses. From one, epidemiological studies indicated that invasive fungal infection may occur in between 4 to 5% of COVID-19 episodes requiring ICU admission. Given that in one, galactomannan testing is rarely available and the fungal diagnostic are sparse, this is likely an underestimate of the real burden of IPA in patients with COVID-19 requiring ICU admission. Recent reports from Europe indicate that IPA may occur in up to 30% of COVID-19 patients requiring ICU admission. In this paper, fungal infection complicating COVID-19 with rain comes the spores, the author states that among critically ill patients with COVID-19, particularly secondary fungal infection caused by Aspergillus and Candida, are increasingly described. They therefore have tested special issues focusing on fungal infection complicating COVID-19, and they see that a total of 7 high-quality papers were published within this issue. COVID-19 associated with pulmonary Aspergillus, CAPA, has been reviewed in detail by many authors, and they also shed light on the immunopathogenesis of CAPA, which is believed to occur due to a defective immune response in patients with severe COVID-19, leading to, this is important, to an hyperimmune state and a dysfunctional T lymphocyte infection. After I will talk about our autopsies, because we have more than 150 patients, COVID patients, autopsies, that is the largest number in the world. The release of danger-associated molecular patterns during severe COVID-19 may contribute to pulmonary epithelial damage. Collateral effects of host recognition pathways required for the activation of antiviral immunity may paradoxically contribute to a highly permissive inflammatory environment that favors the development of a pulmonary mold infection. The recent guideline has been shown that CPA to be associated with increased mortality that can only be lowered by early initiation of antifungal treatment. Thus, early diagnosis is essential. Some authors suggest screening patients with severe COVID-19 in intensive care who remain unwell using a combination of fungal biomarkers, which include culture and galactomannan of deep respiratory sample, serum galactomannan, and 1,3-beta-glucagon, and molecular study as well as computerized tomography. Lastly, but equally important, is that the early initiation of an appropriate antifungal therapy when is a secondary fungal infection are suspected. That means that the global emergency of antifungal resistance in the two major fungal pathogens has made the treatment more challenging, given that there are only a few classic of systemic antifungal agents. Some authors report and they publish the case of CPA due to triazole resistance to Aspergillus fumigatus, while Posterators and other authors present a case of echinocandin resistant to Candida glabrata, bloodstream infection, and so on. So we need to be very careful. As the global pandemic continues, we cannot overemphasize the need for a low threshold to screen for fungal infection for early diagnosis and allow appropriate antifungal therapy. In another review, for fungal pathogens where this is very recent, published, were reported from 3 different studies, and namely Candida albicans, Candida glabrata, Aspergillus flavus, and Aspergillus fumigatus. I don't read the percentage because it's not important. Fungal co-infection and their impact on COVID-19 patients are still understudied. CDC of Atlanta state that the symptoms of some fungal disease can be very similar to those of COVID-19, including fever, cough, and shortness of breath. Laboratory testing is necessary to determine if a person has a fungal infection of COVID-19. Some patients can have a COVID-19 and a fungal infection at the same time. For the CDC, the most common fungal infection in patients with COVID-19 include Aspergillus or invasive candidiasis. These fungal co-infections are reported with increasing frequency and can be associated with severe illness and death. Awareness of the possibility of a fungal co-infection is essential to reduce delay in diagnosis and treatment in order to help prevent severe illness and death from this infection. Scientists are still learning about aspergillosis in people with severe COVID-19. In the past, scientists thought aspergillosis occurred almost entirely in people with a severely weakened immune system. However, aspergillosis has been increasingly reported in patients without weakened immune system, but who have severe respiratory infection caused by viruses, including influenza. Several recent reports describe COVID-19 associated with pulmonary aspergillosis. Available information indicates that CAPA usually occur in patients with severe COVID-19. Secondly, can be difficult to diagnose because patients often have no specific symptoms and testing typically requires a specimen from deep in the lungs. Thirdly, can cause severe illness and death. Fourthly, clinicians should consider the possibility of aspergillosis in patients with severe COVID-19 who have worsening respiratory function or sepsis, even if they don't have classical risk factors for aspergillosis. Testing for CPA usually involves obtaining specimens from patients' lower respiratory tract, which are tested for aspergillosis, galactomannan antigen, and fungal culture. For Candida auris, we can say that it's an emerging fungus that can cause outbreaks of severe infection in healthcare facility. In the USA, it has most commonly spread in long-term care facility, caring for people with severe medical conditions. However, since the start of COVID-19 pandemic, outbreaks of Candida auris have been reported in COVID-19 units of acute care hospitals. These outbreaks may be related to changes in routine infection control practice during the COVID-19 pandemic, including limited availability of gloves, gowns, and the reuse of these items, and changes in cleanings and disinfection practice. New Candida auris cases without links to known cases or healthcare abroad have been identified recently in multiple states, suggesting an increase in undetected transmission. Screening from Candida auris colonization, an important part of containment efforts, has been more limited as resources in healthcare facilities and health departments have been diverted to respond to COVID-19. Patients hospitalized for COVID-19 are at risk for healthcare associated infection, including candidemia or bloodstream infection caused by Candida. Fungal infections resistant to antifungal treatment have also been described in many patients with severe COVID-19. Early diagnosis and monitoring for Candida infection and antifungal resistance infection are the key to reduce death from COVID-19 in patients with severe COVID-19 and fungal co-infection. This is the part of our new study and experimentation. I work with the University of Milan, Politecnico, the chair of chemical, and we have done many discoveries about this virus. And we are studying now new aspects that include proteomics, genomics, transcriptomics, and just to find the metabolomics. We study of the lung metabolome in viral infection and focus predominantly on influenza virus. We have 6 studies till now. With one additional study on respiratory syncytial virus. Influenza virus studies were performed in ferrets 1 study and C57BL6 mice. This is a type of mice that we are studying. 5 studying with all but 1 study using MS. What about fungal infection? Few studies have investigated about small molecule change. This is what we are doing in the lung in response to fungal infection. 1 study detects siderphoresis produced by Aspergillus fumigatus in the lung of infected immunosuppressed rats. A 2nd study used NMRA to show increases in lung and pathogen-derived sugar, lipids, and alcohols in Cryptococcus neoformans infect rats. This likely represent Cryptococcus adaptation to survive in the host environment and microbial metabolism. In other terms, metabolic modulation has been successfully deployed in several studies as a therapeutic strategy against respiratory infection disease, particularly in the context of immunomodulation. For instance, shifting human macrophages to increase states of aerobic glycolysis has been identified as a potential therapeutic target in mitigating Mycobacterium tuberculosis replication in these cells. Also, inhibition of lactate production via targeting of lactated dehydrogenases A and Riscus RIG I-like receptor mediate type 1 interferon IFN production and leads to enhanced protection from vesicular stomatitis virus in multiple tissues, including the lung in mice. Applying existing
Can you please conclude? We are running short of time now. Thank you.
Yeah, fuori tempo.
Okay, I conclude. This is my last, my last slide. Applying existing metabolomic and lipodomic data acquired from this study of respiratory infection to the development of novel metabolism-focused therapies should therefore be strongly considered going forward. This is particularly important for respiratory disease in which no specific therapies exist, such as SARS, Middle East Respiratory Syndrome, and coronavirus 19. Given the severity of this disease and the fact that the lung metabolic alteration are observed in a broad range of respiratory infection, we expected a severe coronavirus infection to cause a significant change in the lung metabolome. Thank you. I'm sorry for using too much time, but I give you my slide and you can use to spread out just for the people that can be interested in this study.
Thank you, Professor Curino. I'm so sorry to interrupt you. It was like music to my ears, but because of the time constraint, we have to.
No problem.
It was a very, very comprehensive and lucid talk. Thank you, Professor Curino. We move on to the next part of the program. It's a privilege to invite Dr. J.N. Verma. Dr. J.N. Verma is founder of Lifecare Innovations. Lifecare Innovations was established to make India self-reliant, especially in field of liposomal amphotericin. He is basically a liposomal scientist. He is recipient of 3 national awards and conferred twice the Vigyan Ratna, the Jewel of Science by Government of India. No better speaker than Dr. J.N. Verma to talk about all amphotericin B formulations are not same. Over to you, Professor Dr. J.N. Verma.
Thank you, Dr. Javeri. Good evening, everyone from India. First, I would like to express my sincere appreciation for connecting with this panel discussion on mucor in COVID. Since 12th of December, news about widening crisis of mucor in COVID patients has been pouring in from different parts of India. Thanks to Dr. Manish Munjal, who is on the panel here, and to Dr. Parth Rana and Dr. Atul Patel in Ahmedabad for creating awareness in this part of the world. This morning, news carried a report about an eminent writer who first lost an eye and then succumbed to mucor infection. Ironically, he could win the battle against corona despite no specific cure, but unfortunately lost to mucor despite a specific drug being made and available in India. India's Science and Technology Ministry, however, has been proactive. The government supported the scientific mission to design, develop, and manufacture a superior alternative to liposomal amphotericin B that was being imported. The drug, called fungizome, is innovated in India, was subjected to all phases of clinical trial. In fact, it is the only liposomal amphotericin B injection that has gone through clinical trials in India. Lifecare Innovations was created specifically to take fungizome from research bench to patient's bedside. The company was formed with support under Self-Reliance Program of Government of India, the first Indian company to make a liposomal drug. Number of liposomal drugs are commercialized and several are in R&D pipeline of Lifecare Innovations. Coming back to the subject of discussion today, it is all well known that early treatment with appropriate drug can minimize morbidity and mortality caused by mucor and other fungal infections. Rational use of evidence-based medicine with proven efficacy, toxicity, or safety, and the dose cost is key to successful treatment outcome. To make this informed decision, I am presenting to you evidences over the next few minutes. There are very few antifungal drugs, and they are mainly azoles, echinocandins, and amphotericin B. Because of narrow spectrum, poor efficacy, and emergence and rise in fungal resistance to azoles and echinocandins, amphotericin B has been the mainstay for treatment of systemic and invasive fungal infection. Its dose-limiting toxicity, however, has been a major concern. All amphotericin B formulations, even lipid or liposomal formulations, are not same. In fact, a liposomal amphotericin B in Argentina, a claimed copy of Amazone was withdrawn for lack of assumed efficacy and referral safety. One Indian company's liposomal amphotericin B was also reported to be subpar to the innovative liposomal amphotericin B. Similarly, a colloidal dispersion of amphotericin B has been pulled out of market as it was unacceptably nephrotoxic and lacked efficacy even at a high dose. Since they are all not the same, it is important to look at clinical data to make an informed choice. This extremely morbid infection with 50 to 80% mortality has just 3 drugs of variable efficacy to treat. These are amphotericin B, osaconazole, and isavuconazole, as highlighted here. Of these 3 drugs, only amphotericin B is potent broad-spectrum antifungal and antimucor agent. The 2 azoles that are mentioned here, osaconazole and isavuconazole, are narrow-spectrum, as it is outlined in this review, and they are prescribed only when nephrotoxicity of amphotericin B is a feared constraint. So the answer lies in removing the nephrotoxicity. Now, here are the different amphotericin B lipid formulations, which are developed for making the amphotericin B nephrosafe. To overcome this nephrotoxicity, evolving lipid formulations of amphotericin B have been developed. You can see here on the screen that starting from 1959, when this conventional amphotericin B came, and then next product came in 1988, which was a lipid complex, and then came a liposomal amphotericin B, which is in dextrose, and now these liposomal amphotericin B in shellac. So these evolving lipid formulations have been developed. The clinical performance of these formulations are based on the static design of these carriers. As you can see in this table, they vary in their composition. You can see here the ratio, they all vary. They differ in their shape, as you can see here. They all have different shapes. And size, you can see here, they all have different size. And suspension medium, which is mentioned here. High lipid to drug ratio combined with predominance of smaller nanosomes result in low MIC, meaning high efficacy at low dose, and replacement of dextrose and sucrose with saline makes this liposomal amphotericin B free of nephrotoxicity. So now let us understand how the efficacy and safety of liposomal amphotericin B has been improved in fungizome, a liposomal amphotericin B in saline. Let us understand the mechanism. So the optimal drug design has increased the efficacy. Fungizome is free of nephrotoxicity. And how does the lipid to drug ratio improves efficacy? So the lipid to drug ratio here you can see is 45:1. In the embisome, it is 7:1, and in the lipid complex, it is 1:1. And you can see that when you have a higher lipid to drug ratio, you have higher number of the drug-carrying liposome particles. When you have higher number of drug-carrying liposome particles, the dose goes low and the success rate goes high. Because the more number of liposome with optimal drug load, the better biodistribution and then the better efficacy. The efficacy of fungizome is further improved by nanosizing by bedside sonication using a specifically designed sonicator for hands-free use. Sonication further increases amphotericin B bioavailability, plasma half-life, and accumulation in their infected area. These features collectively culminate in the lower MIC, which is shown in the next slide. You can see here, during amphotericin B formulation development, conventional amphotericin B is used as a reference. Now, minimum inhibitory concentration is a test to determine potency. Higher the MIC, lower the potency, and vice versa. As seen in this table, embisome has 4 to 5 times higher MIC than the reference drug. Whereas fungizome, the MIC is 1/4 to 1/8 of the reference drug. You can interpret from this data that fungizome is 2 to 16 times more effective than other liposomal amphotericin B. This 2 to 16 times lower efficacy, lower MIC of fungizome is reflected in its high efficacy and makes it a rational choice to treat mucor infection so needed for COVID patients and besides other infections too. Now, let us see how the replacement of dextrose with saline makes fungizome free of nephrotoxicity. During clinical trials, and more than 300,000 infusions so far, no nephrotoxicity is reported by fungizome, which is a hallmark of this innovation. Saline cuts feedback from the distal tubule for constriction of afferent arteriole and thus prevents the renal impairment. A long-standing problem of amphotericin B nephrotoxicity has been overcome by stabilizing liposomal amphotericin B in saline, which is now produced and available as fungizome. So now let us take a look at this table, which shows the difference in liposomal amphotericin B in saline vis-a-vis the other liposomal amphotericin B, all other liposomal amphotericin B. You can see this fungizome has a lower dose of 1:3 milligram per kg body weight per day. And while all other liposomal amphotericin B have a dose 3 to 6 milligram per kg body weight per day. In the clinical trials, in every phase of clinical trial, the efficacy was more than 90%. Whereas For Ambisome, the efficacy varies from 40% to 77% in different trials and studies. You see here the most outstanding feature of this fungizome is that there is no nephrotoxicity detected, which has been a major concern for over 60 years, whereas the Ambisome carries nephrotoxicity up to almost 27%. Because of these features, and particularly the nephro safety of fungizome, it was included among it has the distinction of being the top medicine innovation in a decade in India. This is the press release by the government of India when fungizome was launched, showing that India has also succeeded in developing its own liposomal amphotericin B. Thank you very much.
Thank you, Dr. Verma. That was a very lucid overview about the drug. And you know Fungisome like your own baby. It's always so pleasant to hear from you about Fungisome, the dynamics, the kinetics of the drug. Thank you, Dr. Verma. We have some questions for you as well as for Professor Trino, which we'll take in the Q&A session at the end of the meeting. We move on to the next talk. I am privileged to invite Dr. Manish Munjal, a highly skilled ENT surgeon, a true academician, and a thorough gentleman. He comes from Sir Gangaram Hospital. He is an invited faculty in voice and airway surgery. No better person to speak on this topic, clinical manifestations of mucormycosis in COVID. Over to you, Dr. Munjal. Dr. Munjal, please. Dr. Munjal, no issue. We'll come back to him. Because of paucity of time, we'll start with the next session. I take privilege in inviting Dr. Lily Verma. Dr. Lily Verma is a surgeon by training. She is a founder and medical director of Lifecare Innovations. She is responsible for clinical research of innovative drugs. The research which has been led by her has led to 5 liposomal drugs from bench to bedside. And it's a very proud feeling in inviting you to this forum. It always feels immensely proud when we have drugs which are coming from Indian research. Over to you, Dr. Lily Verma.
Thanks, Dr. Javeri, for inviting. Let me open my presentation. Good evening, everybody from India. Today's topic, as we all know, mucor, COVID-19 and mucor. We all know that mucor is a dreadful disease. It's very difficult to treat and the mortality is very high. Previous speakers, actually, we are hearing from previous speakers about aspergillosis. Aspergillosis is maybe frequent in other countries, but India, because mucormycosis is more common in diabetics, and especially the patients, those who are receiving steroids, are more prone to mucus, and we Indians have high incidence of diabetics. So mucormycosis is more common in India, and especially in COVID, we are hearing a lot of cases about mucor. So today I thought that I should share my experience, not my experience, drug experience on mucor. With our drug, Fortunately, we have different experience and we have different story to tell. As it is known as a more difficult to treat, but I'll show you cases which could be treated with very low doses. As you see, my first slide, this patient is reported from PGI Chandigarh. The patient was suffering with pulmonary zygomycosis, and it was a proved case. And with dose as low as 1.5 milligram, the patient could be cured. There was no relapse. So we know that for mucor, usually for other liposomal amphotericin B, the drug dose is pretty high. As here, ISHAM, the International Society for Human and Animal Mycosis, they suggested just a dose of 10 to 15 milligram per kg per day. This is very high dose. And this is not FDA approved also, but still this dose was used because lower doses were showing high mortality. And with high dose, there's another problem. The problem is nephrotoxicity and also a very high cost to the patient, kind of unaffordable. The next case is from PGI, Sanjay Gandhi PGI, Lucknow. Here you see a very bad, ugly looking lesion on the face, lower face of the patient. This patient was immune competent and suffered for last 2 years. And the diagnosis was very late. And then whatever treatment was given to the patient did not respond. Finally, we had to give Pungisome. And with 1 milligram per kg dose and with Pungisome gel topical, the patient could be cured. He responded very well and he was cured in less than 2 months. The next case, this is a very interesting email we got from NGO. The NGO was taking care of a child, a girl, who was suffering with mucormycosis and was being treated for cancer. The girl lost one eye. Just hold on, please. I don't see the pointer option. This girl, as you see here in the email, the girl lost one eye and doctor had pretty much given up on her because of her repeated fungal infections. The last ditch attempt was prescription of Pungisome injection. We provided Pungisome injection and you see the response, her positive response to Pungisome was there. She was cured of mucormycosis, she was cured of cancer, and then she was bitten a prosthetic eye, and now she is enjoying school and normal life. This is an example from Sir Gangaram Hospital. The patient has mucobrain along with cancer, and he was given 29 grams of Pungisome total dose. The patient could tolerate Pungisome very well without any toxicity, and he was cured of mucor. See, in mucormycosis, it needs very long duration treatment. Here is example of 256 infusions. See, when you have to give a drug for very long duration, there are a few things. The dose has to be less, and the patient should be able to tolerate the dose. The patient was given 1 milligram and 0.8 milligram after that for long duration, 256 doses. Still, the serum creatinine remained within normal limits, and the patient could be cured. The patient was immune compromised. So these were the cases which showed that Pungisome, our experience was very good, and we have good story to tell you. we have done MIC studies of fungizome, and as we heard that Candida auris, Candida hemoluni is resistant infection, not responding to any other infection, but fungizome has been tested for MIC study, and MIC studies were done, and we found that fungizome works on these microbes, fungus. Prednisone, as you have seen in all these cases, is used in very low doses, 1 milligram up to 1.5 milligram, maximum 2 milligram, though the dose of fungizome is 1 to 3 milligram. And it could be given for long duration, and patient can tolerate it as long as patient requires the drug. And I mean, in all our cases, all these cases I presented, patient did not suffer any nephrotoxicity. So this was really a life-saving drug which was given to the patients. Thank you.
Thank you, Dr. Lily Verma, for a very, very lucid talk about fungisome and the clinical usage of the drug. We'll move on to Dr. Munjal. Over to you, Dr. Munjal. Right now? Yes, please. Yes, please. All right. So you can see the screen, I think, now, isn't it? Please just give me a confirmation, then I can start. Yeah? Yes, please. I'm sorry, I had to rush down for something really, really important, but I'm back here, and I would like to really thank all the heads at. It was actually a chance to meet some legends here, and Dr. Verma and Lily Verma. We've been using your fungicide drugs since I was a resident, and as of now, also, I'll tell you some limitations of the thing if you want to. But I'm really proud of the fact that my country can produce such a highly sophisticated drug for at an affordable price. This was a topic which was always close to my heart, and in the annual ENT conference in 2010, as long as back as that, I had presented my series on rhinoorbital mucormycosis, and it was very well received throughout the country, and it was a eye-opening disease for many people. But now in the COVID time, we'll just share a little bit more. The only thing is that it's an ongoing process. We've just started having these cases with the second wave, and for some strange reason, they are just pouring in quite a few in number, as you must have seen from the reports. So, well, there are so many fungal sinusitis issues, as the professor from Italy was saying, and especially various types, various invasive, non-invasive infections that you see on. But the broadly speaking, for the clinical mycologist, when we give a sample to them, the absence of fungal hyphae within the mucosa, even if you see fungus inside a sinus sample or any sample in the body, is termed as non-invasive fungal sinusitis, which means you don't need antifungals for this disease. Whereas when you send a sample and there is a fungal hyphae within the mucosa, the submucosa, bone, blood vessels, whatever you give to the person, and they identify it, then it is invasive. So this is a very important rule where the antifungal therapy starts. So your mycologist has to be trained to see tissue samples and invasion, almost like a histopathologist. We are fortunate in that. The non-invasive type goes into further into allergic fungal disease, which you see in sinus cases a lot, predominantly the species being Aspergillus niger. And also sometimes it forms a very constricted kind of a mycetoma, which is just lying there, sometimes causing nothing, but sometimes because of the... hello, am I audible, please? Okay. So sometimes it forms that kind of a disease. And invasive, the most important one that we are talking about is the one which is highlighted here, that's the acute invasive fungal sinusitis. Then there are various other categories like chronic invasive, chronic granulomatous, and that's what exactly was the issue, that it is a little bit confusing when it comes to other species like Aspergillus causing different types of fungal invasion. But let's talk about the acute invasive, which is the most lethal form of fungal sinusitis, and the mortality rates, even with or without treatment, are in the range of 50 to 80%. It is rare in immunocompetent patients, as has been pointed out. Two clinical populations were the norm earlier when we used to see they were poorly controlled diabetics, and the other one were immunocompromised patients with severe neutropenia, like chemotherapy patients, bone marrow transplants, organ transplants, AIDS, and whatsoever. But now we have another huge category, which are called the post-COVID convalescence cases. And we are exactly trying to find out through various studies what is exactly causing these invasive fungal infections in these patients. The main uh, fungus that we've been isolating, and you see grossly, is basically the Phycomycetes class, that's the mucorales. It has got some other genera. It's mainly known as rhinocerebral mucormycosis, as most of the honorable faculty knows here. Three genera responsible include Rhizopus, Sepsidia, and Mucor, out of which Mucor we found as one of the most deadly. But there are some other species. And we believe that it thrives on an acidic pH and a glucose-rich medium. So automatically you come to diabetics in that, and people who are going to diabetic ketoacidosis especially, they are very, very vulnerable. Probably the hyperglycemia induces the neutrophil chemotaxis and impairs the glutathione pathway. And of course, Rhizopus species thrives on an iron-rich environment. So transplant patients, especially KTB patients, are a good source for them. But what if it happens? Early detection is the key. Recognize the symptoms. We are talking especially about ROCM. These days, I have spent out a special advisory to the government of India through Dr. Paul, and we have sent to various hospitals that if we have some patients in the scenario, even in the OPD, who have been complaining of a specific headache, nausea, fever, lethargy, these are non-specific symptoms, but then going specifically to periorbital or retroorbital pain, diplopia, blurred vision, nasal symptoms like purulent drainage, stuffiness, rhinorrhea, epistaxis, hyposthesia on the cheeks, or of course, in the very unsure state, convulsions, altered mental status, and all, which you can't make out. You must not dismiss them as migraine, because you don't want to see those patients coming into a situation like this. And this patient is not after 10 days of therapy. He came in walking and he was like this on the second day, and we could do nothing. He's one of the 5 mortalities we've seen recently. Of course, a good ENT or any physician can see a few things like a graying erythematous appearance of the nose and the palate, which can later progress to black. Black is a little bit later though. Acute and non-specific inflammation happening, any cranial nerve palsy in this 2nd to 8th range. You can find ocular findings ranging from a swollen eye to a painful eye to slight proptosis, a pupil that is fixed, and an eyeball that stopped moving well, and blindness, of course. Sometimes the disease is really insidious, and in one disease, in one of my patients, this is way long back, this is all I could see in a headache patient who had come and was admitted with a neurologist. This was all I could see. So scans can help, but then clinical suspicion is very important. So I would say that imaging has to get smarter, and these days we've got various criteria to find out about the early CT findings and early MRI findings in these patients. And rather looking at the sinuses, we look at the tissues around them, so that we can see the spread of disease along vessels beyond the sinus, because it really does so. It doesn't follow sinus rules. It goes out very fast. So cavernous sinus, the pterygopalatine fossas, the areas just going from the Sylvian fissures and all these things, they are the important areas where physicians or the radiologists need to know.
Of course, in centers where MRI is the availability thing, we can have a good MRI that can tell us so beautifully about the tissues planes. Even though this eye is all normal, you can still see some rectus muscles swelling up here and there, the fat changing its direction, some edema on these areas. So there are so many signs that an MRI can tell you which a CT can't. It is a better thing, no doubt, but sometimes it is not available. But once the disease is done, we must decide on the treatment module. It does require aggressive debridement, systemic fungal therapy. We do need a reversal of the underlying cause of immunosuppression. Recovery from neutropenia is the most predictive form of survival. At least it was in the pre-COVID era. And intracranial spread is the most common predictor of mortality. If there are any physicians who want to treat mucor who have to, sample collection is the most important part of the mucor treatment, because if you're suspecting it and you do not get a mucor positive sample, it is very difficult to put the patient through such a troublesome therapy and surgery. So use peripheral tissue samples encompassing disease and healthy areas. Middle terminate samples in the nose are the most helpful in early cases. Do look for speckling. Do not add preservatives in saline or glucose. Do not crush them. They are very sensitive samples. This is a very sensitive fungus. Even start of antifungal therapy can make the presence of the fungal hyphae to zero. You will have a picture like this on that day, and the next day you will have nothing but these kind of tissue zones. So be very careful. You have to form a multidisciplinary team. Dr. Pooja Khosla is frankly the more important member in my treatment of mucor than myself. Definitely, I can tell you that. That's why I put my name in the last, because I have to do what they tell me to do. You have to see where they start the disease process treatment, where they give you the nephrologist gives you the kidney weightage, how the neurologist thinks we should go ahead, and of course your ophthalmology person. We have got some beautiful guidelines now, and I've been working really hard on it. And we have started staging our cases of mucor, where we see the subunits where the mucor is there, like stage 1, then stage 2, where it goes out of the nose, more than 1 unit in the nose. Then we go into the, whether it's involving the lamina praeparatio of the eye, is it going to the skull base? I'm just running through these things because we need to complete. If there is extranasal spread, if there is significant nasal spread, and depending on that, the recommendations are there, where we have debridement, and concomitant therapy, where we need to do some orbital exentration, where we can give injectable local amphotericin therapy, and after that, what big surgeries can be done. Of course, the poor prognostic indicators like poor GC, sensorium, uncontrolled diabetes, neutropenia, and chronic renal disease is important. We have a definite protocol, and amphotericin B stays as the gold standard of treatment. We have all mentioned how it should be given. I'll not go into the details, but it requires daily creatinine and potassium monitoring, and you must make sure there is no hypoalbuminemia, and even creatinine levels are below 2 at all times. We are giving some local amphotericin sprays also with formulations. There we are not using the liposomal one, we are using the plain one. We have to prognosticate them early, right? Because it has a big mortality, especially if there is a brain involvement. We decide all the exclusion criteria also. If there's a very poor GC or the family situation, intracranial, they're all out cases. The surgical experience, as you've asked for, requires a widespread endoscopic debridement, orbital exentration. If fungal load is too high in orbit, external debridement, if facial areas are widespread, and multiple stages may be planned over 4 to 6 weeks. Check endoscopies are the norm every week. Washes and amphotericin gel is also installed. I know fungizone gel used to be available. We are not getting it anymore. This is an early mucor, and it's more important to test these, where you see the speckling here, but this is a late one where you still need to do the sample properly. Of course, during the course of treatment, it starts to get better. And this was our data from 2007 to 2011, which I had published in one of the journals in India. And we had a mortality rate of as high as 50% or more at that time. We were not going too high. We were not into too much of amphotericin liposomal at that time also, and we used to get really low doses, if you see that. But we still were encouraged by the presence of high generation drugs like fungizome, and we have started really learning over the last 7-8 years. This is a result of my 2011 series, but now what is most important in the next 2-3 slides, which I'm going to finally tell you, is what has happened in the COVID times. I, from 15th of November, was very alarmed to see the amount of mucormycosis that was pouring in through OPDs and hospital emergencies. And we were having cases outright and center, whereas we used to see 1 or 2 cases a month in a tertiary care hospital like Gangaram. We have at this moment a shortage of beds for them, and we have, as I speak now, even 7-8 cases admitted. In fact, I ran down to see a deteriorating mucor patient right now as we speak. Dr. Paul had definitely called me up and put this in the news bulletins that we really have to keep a check on this disease. Till yesterday, we had 28 cases, maybe an addition of 3 today, and we have 3 active. These are mostly post-COVID cases, convalescence cases, but we have 3 cases who are active COVID, maybe the 4th one today or the 5th also, who is active COVID now. All patients, although we are collecting the data, but we can tell you all patients out of these received corticosteroids as part of primary COVID treatment. They are moderate to severe ones. We have had only 5 mortalities in the post-COVID dose. This is a little bit surprising. We didn't have as many mortalities I used to see earlier. We have been starting since 15 November, and we have reached a dose range of 3 gram to 8 gram continuously as of now. We have become more innovative. Along with other things, we are adding oral posaconazole and voriconazole, even if you say have reservation, because we have had some evidences of mixed infections where we saw septate hyphae as well. And we have so far in the last 1 month operated through various units around 25 patients of these cases. So in almost 30 days, 25 mucor patients in Gangaram have got operated, which is a huge number. It's almost an astonishing one. 8 have lost their partial or complete eyesight. 3 eye resections have been done. 3 partial upper jaw and nasal bone resections have been done. So we are still learning. I cannot disclose too much because we are in the phase of learning about it. We will all have our data encouraged in this. But if we go, a multidisciplinary team is most logically way to manage it. A high dose liposomal lipid complex formulation is the key to success. We have done away with conventional amphotericin because as Dr. Verma said, you never know where to stop in amphotericin. You don't want to stop because of the creatinine levels. And as far as possible, a surgical debridement, early debridement must be employed in every treatment. Post-COVID survivors, patients are, however, better survivors. We are seeing a less than 15% mortality. It's a long-drawn battle. Can't still tell you clearly, but it is a better thing. We have submitted 2 research protocols as we speak. One of them is undergoing both of them are undergoing ethical clearance, but one is a critical care initiated trial on post project on multicentric mucormycosis and COVID mortality and study, and this is being taken command by Professor Chakravarti. And the title, the other one, which is a complete Gangaram project, is a prospective observational study on epidemiology, clinical presentation, risk factors, and treatment outcome. This is a very exciting paper. We hope to come in the next 3-4 months with this paper. Finally, I would like to thank the Lifecare Innovations team for bringing the drug to India. It has a little bit of limitation. Sometimes we are not able to use it all the time. And I'll just highlight 2 reasons. One is that it's a high volume hospital. Sometimes you just want to give it in as fast as possible, patient coming at some time, and our staff is at night sometimes not trained for doing the sonification and things like that. It delays the thing. And of course, a lot of these patients who have been discharged for home care are being prescribed amphotericin B by us on an ambulatory home therapy. So how to get it done? I have tried to talk to your representatives about it. It would be a problem. So you have to see that. Thank you so much. With that, I will end my presentation.
Thank you, Dr. Manjal. It was a deep clinical insight into mucormycosis, and you taught us many secrets of the trade actually.
Yeah.
And you highlighted how not only surgical excision, but a multidisciplinary teamwork, right sampling, everything has its own important role in diagnosis and management of mucormycosis. With this, we move on to the last part of the program. We have the panel discussion and Q&A session. I'd like to invite Dr. Pooja Khosla. Dr. Pooja Khosla is a renowned senior physician at Sir Gangaram Hospital, Delhi. She did her medicine training at Christian Medical College, Ludhiana, and she brings with her vast experience in internal medicine. She has worked at Sitaram Bharatiya Hospital before joining Sir Gangaram Hospital in 2004. I'd like to invite other panelists also for the question and answer session here. My first question will be to Dr. Pooja. Is the incidence of mucormycosis in COVID, is it truly representative of the epidemiology?
So, good evening, everybody. Now, incidence of mucormycosis, we are learning with the time. There's this sharp escalation of cases in last about 2 months, as Dr. Munjal has discussed with you. I think we did not get so many mucor cases during the first wave of COVID. And in the last two peaks, we are getting more cases, and in time to come, we will maybe get more data. So we've treated about 1,500 to 2,000 COVID patients in last couple of months. And as he rightly discussed with you, that we've got about 31 cases as for now. So which makes it less than 0.5%. So this data may change with time. And in fact, we are getting aspergillosis much higher rate than mucormycosis as on date. And most of the mucor cases, what I have observed, we're getting those cases in patients who are either diabetics and poorly controlled diabetics. So mucor, diabetes, steroids, is it a combination of three? So that is the basic case scenario. And fungus is, if it's a pre-existing or if it's newly picked up fungus during that time, the cases there's a sharp escalation. And voriconazole we've been using after a couple of days. What we learned in the first wave, that most of the cases are aspergillus. Maybe voriconazole is adding to the more sharp rise in the cases of mucor. I'm not sure.
Yeah, perhaps those were some papers also, and we also have same feelings, but too early to decide on that. I'll ask the same question to Professor Curino. Professor, are you around? Professor Curino.
Can you hear me? Yes.
Professor, are you also seeing mucormycosis associated with COVID? Mucormycosis. Are you seeing mucormycosis in COVID?
Yes, of course. Not many cases, but because our diagnosis is always too late. We don't have a real way to make a very precise diagnosis to put immediately the anti-fungine therapy. I learned something very interesting from the other talk, but we need to be more important to associate the fungal infection to COVID-19 earlier that it's possible, just to reduce mortality and morbidity, because we know and we learn from the anatomopathologist lesion of the pulmonary autopsies that the field of this lesion prepare a very easy going to spread out also to the infection of fungi. So what is really important is my message that I give to all the world that unfortunately the patients of COVID-19 reach the hospital too late, and the therapy is not well began, especially about heparins. I remember I have a webinar in India on March, and I say that is fundamental, is a pillar of the therapy anti-COVID to administer the high dosage of heparin. And all the other speakers say, you are talking about 8,000 units of heparin. I say, yes, because we find after in 150 autopsies that the microangiopathy and the microthrombi starts immediately. Also, if you have patients without fever, without cough, it seems without any sign of COVID. And we find with the CT scan after 1 month, this result is a very terrible virus, very insidious, and we must take we must be very ready to give the right drugs at the right moment. This is the right decision.
Thank you, Professor Quirino. Dr. Pooja, Dr. Munjal, I am also trained at Gangaram, and we are blessed to have a good mycology setup at Gangaram. No doubt about it. We move on to the next question for Dr. Munjal. How extensive is extensive debridement for mucormycosis, especially nasopharyngeal or rhinocerebral mucormycosis?
So if you can remember the slide that I showed you, we did not have a proper guideline at one time about this. And I was one of the people who really sat on it, and with a lot of people, we discussed this thing as to when and how much you operate in a rhinocerebral mucormycosis. So we have hopefully brought out a good staging system, and in a very simple imaginative language, I'll see if it starts from the nose. We put the subunits of the nose into perspective, whether it is starting from the earliest site in the nose, like the turbinate or the nasal septum, whether it's going on both the sides. Are there small lesions only involving subunits? Then you need obviously an early debridement, and then antifungal therapy can take over. But if you have a disease which has spread to other subunits, and then the dangerous areas of the body, of the head, like the eye, the lamina pepracia, or the skull base, where you have the cribriform plate and all those things. So anything climbing above the middle turbinate, anything going beyond into the other side, from one side contiguous, then it grades up the staging from 3 to 4, and we have now staged it. In that case, you have to load up the person with a good amount of antifungals in a very high volume, so that when you do the surgery, you're only removing the dead tissue. But how do you bring the drug into the picture which actually stops the fungus from invading into? It's an endarteritis. The mucormycosis does not climb up into tissues through a viral transmission type of a thing. It only destroys blood vessels through microangiopathy, as Professor Curino has mentioned, and then it starts to destroy the blood supply and starts eating into dead tissue. So removal of dead tissue can only be done if it is small, but if it is large, then you have to border the entire area with antifungals and then go inside and do it. Of course, sometimes it's a too late a process. If it's already gone into the brain or into the eye, the brain itself is a very poor percolator of amphotericin. It does not accept, the blood-brain barrier does not take amphotericin or any formulation well, antifungal. So we have already lost the battle once it goes and grossly involves the brain. But yes, eye, orbital exenteration, these all can be planned after you, and it gives time to prognosticate. When you have a bad patient, you give him antifungal for 2-3 days. It is enough to tell you whether it's worth going and spending lakhs on this patient. The drug costs money, so you have to really think whether this patient is worth your treatment. And fortunately, in post-COVID patients, we have found some real inspiring stories. We've been saving, and we've got only a 15% mortality rate, which is unheard of, and we're going to publish it.
Thank you, Dr. Munjal. I move on back to Dr. Pooja. What will be your drug of choice for managing mucormycosis? Rhinocerebral mucormycosis, especially.
Amphotericin B liposomal, and we're starting with a high dose. Mucormycosis is all about right time. If you hit hard right in the beginning, if you have a high index of suspicion, you should not be wasting time. Straight away start with 5 milligram per kg or plus dose. If you think it's gone into CNS, start with 10.
Absolutely.
So it's basically a race against time. Antifungal therapy has to start, surgical clearance has to be done. You have to get hyperglycemia under control. Try to reverse the underlying triggering factor. If it is steroids, try to get the steroids down. If there's neutropenia, you try to get the neutrophils up. Whatever, if it's immunosuppression, try to reduce the immunosuppression. So once you reduce the underlying cause, whatever it may be, and get a good sugar control, hike your antifungals, keep an eye on the kidney, keep an eye on the electrolytes, uh, have a good surgical clearance of the dead tissue. I think you can achieve the target. And mucormycosis scenario, which was like you give a death certificate with mucor, which was there a couple of years back, it is not the case. You can get a good result, if not the best result. Act fast.
Thank you.
And then the most important question in mucor, what I would say is when to stop. When to stop is very difficult because fungus, even one spore is left, it will come back. You have to chase it radiologically, you have to do a clinical, and of course you need a good surgical colleague to give you inputs about the surgery. You may need debridement time and again, and the treatment can continue from weeks to months till the time you are convinced. Again, if you're able to reverse the underlying cause, then maybe you may have a defined end. Otherwise, it can go on for a very long time.
Thank you, Dr. Pooja. You raised a very, very valid point. That conventional approach of escalating dose of amphotericin is gone. We should not follow that conventional approach to give the loading dose. Even there is underlying renal or hepatic dysfunction, you have to give the loading dose, the full loading dose. The loading dose never comes down. Dr. Lily Verma, I'll ask you a very pertinent question. What advantages do you see with fungisome in treating these patients with rhinocerebral mucormycosis and other mucormycosis? Clinical advantages, and what are the pharmacoeconomic advantages with fungisome vis-a-vis other liposomal preparations? Dr. Lily Verma. Dr. Lily, yeah.
Yeah. Thanks, Dr. Jabiri. I have shown you cases in my presentation that they could be cured by giving just up to 2 milligram drug per kg. Never ever given high dose, more loading dose more than 2 milligram. I mean, patients have been treated with 1 milligram, 1.5 milligram of antisome. Why it is so? Because we have seen the MIC. Our MIC is much lower. The liposomes are very potent. I mean, 2 to 16 times lower than other liposomal amphotericin B. And this is why our efficacy at low dose is very high. First thing. Second thing, giving liposomal amphotericin B as such, there is no problem of resistance. You don't have to see the spectrum. You don't have to confirm the diagnosis. You can start immediately. Second thing is that with fungisome, the breakthrough infections will be minimal. There is no drug-drug interaction. So you can give whatever dose you want. I mean, there is no serum estimation or anything is involved. And there is no resistance problem. So that is like the best thing you can do. And I mean, we have tested our drug when we were developing the drug. We have tested in animal, the dose range testing. We have done it in human, and then only the dose is decided. People think 1 milligram a dose because it is toxic. No, 1 to 3 milligram can be given freely. But we have seen in our clinical trials, more than 90% of cases have been treated with just 1 milligram dose.
Thank you, Dr. Lily. This brings us to a very interesting question. I will put this question to both Dr. Pooja and Dr. Lily, both of you. So, if you have a case of rhinocerebral mucormycosis,
Yeah.
what dose of fungicide will you use? Will you use 1 milligram per kilogram or will you use 3 milligram per kilogram? My take, I will use the maximum allowed dose.
Yeah, the dose decided is anyway 1 to 3 milligram. So you can give 1 to 3, I mean, up to 3 milligram.
Okay.
But what we have seen, maybe you can start with 3 milligram and then come to
Absolutely.
2 milligram, 1.5 milligram, or 1 milligram. That because the liposomal amphotericin B is expensive proposition. So you have to see both. You have to save a life as well as you have to see the affordability of the patient. Both the things.
Yeah. Dr. Pooja, you agree with Dr. Lily?
I agree with Dr.
Yeah.
Verma totally.
Yeah.
Hit hard in the beginning,
Absolutely.
and if you're getting very good results, you can gather some courage and reduce the dose.
Hit hard, and then as we de-escalate therapy, the dose can also be de-escalated and brought down to 1 milligram per kilogram. Liposomal amphotericin is a class of drug which has stood the testimony of time. Probably no other class of drug in world has not seen resistance in so many years. This is one of the molecules which holds the testimony of time. With this, we come to the end of today's program. I will request Dr. Lily Verma for the vote of thanks.
Dr. Javeri,
Sir.
I would like to answer a pertinent question raised by Dr. Munjal. This is about the logistics of sonication. We have been serving the patients across the country and around the globe, and we have not faced this problem of sonication. We have handled patients. We reach the sonicator to their homes if required. I would suggest that when our representative will visit you, you please hear them out. We will make all arrangements. You are only one phone call away from us. In any part of the country, we will take the liposomal drug as well as sonicator, demonstrate to the staff, and we will make it a very smooth treatment. Okay. So you can ask any questions and we are there to support you. We must together work to save lives.
Wonderful. I really appreciate it, and I think it will go in a long way. And I think, furthermore, I think the technology will continue to develop. I think there will be a day we can have a ready-to-use AMPO. I am quite sure it'll make things a little bit easy.
Sure.
Dr. Lily Verma.
Yeah. In the end, I want to thank all the honorable panelists, participating doctors, and the audience. See, this was our effort to bring the awareness for the seriousness of fungal infections in COVID-19 patients, especially the mucor, which used to be a very, a dreaded disease. If you need any more information about fungizome, you can visit our official website, www.lifecareinnovations.com, or you can go to our social media handles. Thank you very much.
Thanks all the faculty. I'll invite Komal for her closing remarks.
From the above, from this live discussion program, it can be concluded, as Dr. Quirino and Dr. Pooja have already said, that precious lives of fungal infection victims can be saved by using the right drug at the right time. And I must tell you, the right drug is fungizome, liposomal amphotericin B in saline. It is the only nephrosafe amphotericin B with most potent efficacy. If you pursue the clinical data, you would come to know that there is no drug equivalent to fungizome to treat mucor and other fungal infections. Fungizome, with fungizome, mucor infection of eyes, brain, and cheek have been successfully treated economically at low dose. Fungizome has the distinction of earning a place amongst top 10 innovations of the decade in the country and the only medicine in that list because it is the only nephrosafe amphotericin B injection. If you want to contact us for the fungizome injections or any other further details and the information, you may come visit our website www.lifecareinnovations.com. Even you can drop us a mail at info@lifecareinnovations.com. You can follow us on all the social media handles. I repeat, if our website is www.lifecareinnovations.com. Our email ID is info@lifecareinnovations.com.
Thank you, Komal. Thank you,
I
Mr.
would
Bhatt,
like
Dr. Pal, Professor
thank
Chirino.
Dr. Javert
In the,
for this nice meeting. All the other speakers, very, very nice news from them. And I would like to say namaste, and I hope in a very good new year for all of you. And please, the message to take home is that in our patients, like COVID patients or with co-infection, the innate immunity is a primary immunity and not a little secondary immunity. This is important to understand and to check in the future new fields for innovation and research. Thank you to everyone. Bye bye.
Thank you all. Have a good day. Thank you all.
Good day. Bye bye.
One
Bye-bye.
second now, 1 second, 1 second, dear viewers. This is Pranav here. We are closing the proceedings of the day today. Thank you so very much for joining us. And as rightly said by Kamal, you can contact her. Kamal, are you there? Uh, we
yes,
take
I'm
this
here. I would
opportunity.
like to thank all the lovely audience who joined us, who took out their time and discussed, and they were part of our discussion. Thank you so
Wonderful,
much.
wonderful. Feel free to contact Kamal and Lifecare Innovation website as she advised to her live transmission. And once again, we thanks each one of the faculties who contributed the time, efforts, and knowledge to us today. Thanks. We are deeply honored. Thank you so much.
Thank you. Thank you.
Thank
Thank you.
you.
Bye bye.
Bye-bye.
Bye bye.